And welcome back to this second hour of this global virtual sun meeting here from Lærdal Medical. The next speaker today is Sigrun Anne Kvinnesland. Sigrun Anne Kvinnesland, she is currently leads the preparation for establishing the Norwegian Simulation Network for Hospitals, the RIKSIM West Regional Simulation Network. I hope I said that right, maybe not. She has worked with medical and clinical simulation since 2011 for Stavanger University Hospital and the Safer Simulation Center. She's building on her clinical background as an emergency nurse practitioner, and she has worked as the hospital coordinator for simulation from 2011 to 2017. She also holds a master grade in healthcare science. That position consists of motivation, education, and supporting clinical simulation practitioners to run efficient simulation-based educational initiatives, both at center and in situ. I would like to say that she is a fantastic girl. I know her very well. Is a good friend of mine, I hope to say, or like to say. She's born in the United States, actually, in Ohio. She's part Icelandic, grown up all over the world, and she's a great woman. So without further ado, I just leave the stage to you.
Thank you, Bjørn. Thank you. And hello to the community out there listening. I hope I'm addressing simulation educators and leaders and practitioners and clinicians that are interested in developing competency and improving systems with simulation. It's nice to be here. So I'm going to try and set the stage for two colleagues who are with me this hour, also from our hospital, and they've been working with us as a task force. This is what I'd like to go through the first 10-15 minutes, a bit about our context here in this part of our country, the requests we received from our hospital, a little bit about how we worked as a simulation task force at our hospital, some examples of the activities we designed, a little bit about the feedback and our experiences with our organization running simulation during the last 2 months with the COVID crisis, and then some thoughts about challenges and enablers for running simulation. And just to put us on the map, literally, we are in the southwest corner of Norway, good neighbors with Sweden and Denmark, where Professor Diekman was just speaking, and Finland. And let's see. This is a bit about, this is a picture of our hospital, just for fun. For those of you around the world, it's located in a fjord, like many cities in Norway. And this is a little bit of the statistics about our area. It's a relatively small city, probably compared to most of you out there working in larger cities and larger hospitals. Catchment area of 360,000 people. Employees, about 7,800, many part-time. Somatic and psychiatry beds as such, 500 to 277. It's a bit about us. Before I show the next slide, I just like to put it in some context, because when the call to arms came, or when we were asked to start preparing for using simulation in education for the COVID crisis, I don't think any of us around the world knew exactly how hard it would hit us, but we were preparing for the worst. So that's what I'd like to say before I show the following slides. These are our national statistics as of 2 days ago. So the population of Norway is 5.3 million. Individuals tested as of 2 days ago in Norway for COVID, 234,000. Of those, 8,300 tested positive. And then we have how many people have been admitted into hospitals in general, 873. And then the blue is our hospital, the Stavanger University Hospital. Approximately 51 patients were confirmed positive with COVID-19 admitted to our hospital. And our region of the country has had fewer, relatively fewer than, for example, the East, which has a larger population. And admitted to ICUs in our country, 218 at our hospital, 7. 12 remain in ICUs nationally, and unfortunately, also we've experienced deaths, and at our ICU in our city, 3. So the numbers, especially for our city, are low, but at the time when we received the request to work on simulation, we were preparing for the absolute worst. A little bit about the context where we live and where we work. I think that's, I've been thinking about how we've been working, and this does affect our results and how we performed. So here in our area in Stavanger, we have our hospital, the Stavanger University Hospital with the Department of Education, where there is a strategic plan at our hospital to use skills training and simulation to improve competency and systems. This is an authorized and accepted strategic plan at our hospital. Our hospital has worked very closely with the SAFER Foundation. The SAFER Foundation in Stavanger was established in 2006 as a collaboration between the Stavanger University Hospital, the University of Stavanger, and Lærdal Medical, which is based here in Stavanger. So since 2006, we've been working very closely together to try and improve the use of simulation. And then, as Bjørn introduced, I'm leading RegSim, which is a collaboration of the hospitals in the western region of Norway, where the region expects us to collaborate and exchange initiatives and experiences and ensure the quality of simulation being used in the hospitals. Our leader has said, we don't have time or resources to use on bad simulation. She expects good quality simulation, and that's wonderful to hear from a leader. So that's about our area professionally, and also nationally. At the bottom there is a picture of several of our ministers. In many countries around the world, we have daily press briefings from the government officials. There they are, exercising nice social distancing. And they were, at least I think we experienced them to be very enthusiastic and very much concerned with our health. So they initiated many different things. Rapid quarantine of people who'd been traveling abroad in March and February. And any suspected COVID-19 cases, there was national consensus that people would stay home if they had the symptoms or if they were diagnosed. This was not even a question. Immediate social distancing. The schools closed down the 12th or 13th of March, all the way from the play schools to the universities. Many businesses closed. I think this was also something they had to do by necessity. And a lot of the services were reduced. So the country pretty much shut down. People really observed the practices that were advised by the government. And at the hospitals around the country, they issued lockdowns. So maybe there was only 1 or 2 entrances to the hospitals. Non-essential consultations and treatments were canceled. And around the country, re-entry to clinical practice was advertised from the hospitals, trying to get healthcare workers back into the system to retrain to prepare for a potential huge amount of COVID-19 patients. This was very well received. A lot of people, healthcare workers, said that they'd like to come in, and they received some training. So this is the context of where we're working. So the request, I think this is kind of unique, and it was really, really nice to get this request. It came from our chief medical officer at our hospital through the Department of Education lead to our work group, the people who work at SAFER, the people who work at the Department of Education at the hospital in simulation, and RegSim, my unit. And they asked us specifically for help. They said it was very important for us to emphasize health and safety and infectious disease control as the primary focus for educational activities. The hospital had an expectation that we would help them and that they would focus on this. Then it was important, obviously, to ensure adequate patient treatment. Also, many personnel would need to relocate or retrain to enter the workforce, so we needed to look into those issues. How could we help the hospital design these things? Then, let me see here. Choosing the need to train patient flow and processes. That was also important. They wanted us to look at the flow and the processes of patients flowing through the hospital. An agreement of the senior staff to ask us to help. That was really important. And in the end, to kindly prioritize this work and stay in close contact with them throughout the process. That was a very nice request to receive from our hospital. And I understand that not all organizations and hospitals have gone out explicitly and invited their simulation educators to work with them. So this was a nice place to be at. And I think, again, this reflects how we've worked for many years with our hospital. So we established a task force, and this is how we worked. We received the email from our chief medical officer and education lead on the 11th. We sat down that afternoon and reviewed the hospital's emergency plan for COVID, and we picked out the parts where we thought we could help with the skills training and effective educational initiatives and simulation. And then we put into work subgroups to work on those different points. And we played that back up to the leaders and said, this is how we think we're going to work. And we just took off. We worked nonstop for many days with the clinicians, and we even received requests during the weekend. And if we could, we would send people to work with the wards then. And we had daily staff meetings. Some people were already in quarantine in the work group, and some people were at the hospital. And this is how we planned every single day. We double-checked how we were working and managing our projects. And the last point on this slide is really important. That's how we worked for years. We develop educators. We give them the tools they need and the concepts they need with effective education and implementation so that they can run educational initiatives and educational courses themselves, so it's more sustainable over time. So we can be a tiny workforce, task force that develops and helps and gets feedback from them to ensure that we're providing the best possible education. Some examples of what we worked on, especially the first one was a request from the regional authorities to our work group to prepare a course for first-year doctors so that we could help them phase into working on the ICU in teams, helping respirator patients. So working with ICU nurses and ICU doctors already as parts of teams. We designed a course. There were several of us doing that. And that course has been taken into use in the eastern region of Norway and the northern region of Norway. And it was easily implemented into the electronic course programs and platforms that we have. That was a nice feature, including simulation and e-learning and skills training. Also, phlebotomists and receptionists, especially to begin with, we were concerned about them if they would have some fears about working with potential COVID-19 patients. So we designed some decision-making educational initiatives for them. And so they would prepare themselves mentally for how to go in and get out of the patient rooms and do a good job and to keep themselves safe. Psychiatry wards, there was a request for that, especially from psychiatry. How do we deal with COVID-19 patients in psychiatry? How do we de-escalate situations safely? We worked on projects for that with them. Skills training, which was, again, the cascade model through Skype teaching to all the units. In situ team training is something we've done for years at our hospital. I have to just say we love it, and we do it a lot, and we're getting better and better at it. It's a really excellent way to learn. We ran 70 team trainings in 8 weeks, including trauma, cardiac arrest, peripartum, rapid response teams on the wards, A&E, stroke teams. Martin's going to talk about that afterwards. And of course, we just created the scenarios we used, but the patients all had a question about if they had COVID-19 or not. And we learned a lot. And I'll let Martin tell you guys more about that, how the stroke team learned about that. Donning and doffing PPE was incredibly important. And there were very nice e-learning modules available, but what we saw was people really needed skills training and peer-to-peer feedback. And in the beginning, we were able to be successful with that, but then, of course, we had to take into consideration infection control and trying not to create problems with infection at the hospital. Also, pandemic pop-up cohort wards at our hospital, and I think most of the hospitals in Norway have managed to keep the hospitals with special cohort units for COVID-19 suspected patients, and then the rest of the hospitals are running as usual. And we try to create initiatives just in time for those units, and sometimes we were called in a few days after they started, but we managed to do a lot of teaching for them. The ambulance service, my colleague Kjetil is going to talk to you about that later, but that was a wonderful request to get from our ambulance service to develop courses and help them prepare for COVID-19. Occupational health, like Peter was talking about, personal and psychological PPE. Our occupational health ward is very wonderful, and they were doing rounds to the cohort wards, just preventative rounds, talking to the staff. And reflection discussion groups popped up, a need from the doctors, leads, and nurses to talk about their lives working on pandemic wards. And we also introduced a clinical debriefing tool, Talk Debrief, to them to help them learn quickly from their days. And here's just some pictures of our activities. Up in the left there, some of my good colleagues, they're clinical leads and simulation leads. And they've been working in simulation and clinically for years, and they're talking together. So on the left is our Professor Kurtz from neurology, who runs the stroke simulations. In the middle is Siri Olsen, who's running the critically sick or critically ill teams. And on the right is our trauma lead and trauma coordinator. And they're talking there about the processes in COVID-19 through the emergency department and simulation and the results. And they're working together across specialties. I think that's a wonderful picture. And here's just a typical picture. We stopped in the middle of a trauma simulation to look at the flow through the workplace into the operating theaters. And this is how simulation was helping us learn how to improve our systems. We couldn't use real PPE, so we got some volunteers to make fake PPE, fake masks for us, and that just did enough to confuse or to show people how difficult it was to speak and communicate as teams, and that helped. And this is just some pictures. We took it all the way through some simulations where we had volunteers who were collected at home as COVID patients, and we ran through the whole processes. There's our ambulance picking up a critically ill patient. And then the feedback to the organization. I like this model from Cotter. I think a lot of people in simulation have been working on the left side for years, very innovative, very dynamic. They can move very fast. They can develop simulation. And on the right is more the structure and hierarchy of the hospital. So in the start of the COVID-19, we're working very fast on the left there. Very flat structure, very easy access face-to-face to colleagues. And then as the weeks went by, we had to start, there was increasing interest in reporting our results, reporting to the leadership group, and going back into the hierarchy here and registration of numbers. So this is just something to think about when you're working in organizations. Some of the challenges that you working in simulation and education face anyway, when there's not a pandemic, are often what we call the silos. Different staffs working at the hospital, all working for the same goal. Having highly competent workforce, providing the best care possible. And how do you get these people to work together in peace times? And how do you get these people to work together in a crisis? So some of these staffs knew each other and knew how to work and knew how to bring out the best in each other, and some hadn't worked together before. And it's making quick friends in a crisis is incredibly important to get results. So this is just something to think about when you're working. How to collaborate between the different staff groups and bring out the best in each other. Some of the enablers, now that I think about it, were the sense of urgency. Obviously that helped in the organization. Incredible willingness to move quickly. The clinicians also were concerned about themselves, their families, their patients, and their incredibly high degree of eagerness to participate in simulation. And the society had a paradoxic effect, maybe here and in other countries where people tried to stay away from the hospital and give space to COVID patients if they were there. So that gave us a lot of room to train. Also a shared goal, for sure. And the volunteers we had, they were so happy to sew and make these masks for us so that we could train in simulated equipment. And simulation resources being quickly mobilized. That was something we were able to do because we have a good tradition for using simulation at our hospital. And we've proved the value over years. And we've developed a lot of face trust. Can't underestimate the power of relations and face trust between people to get things done. So build those relations and deliver over time, and you'll get great results. Knowing our organization helped. We were able to call and run over and talk to each other quickly and get things done. And a culture for simulation, like I've talked about. Effective information campaigns. This was exciting. In the organizational level, we have a great media department that had daily briefings. And the national level I showed you, we had very reliable information we feel coming from the government, that they're on our side and they're trying to listen to the people. And just like to say thank you very much, and let Björn take over and give it to my colleague. Thank you.
Thank you very much. Thank you very much. Yes, thank you very much, Sigrun. That was great. Do we have Kjetil on the line?
I hope
He's
so.
there? Great. So I just want to introduce you to Kjetil Torgersen, who is a manager of external training programs and senior facilitator at Safer Simulation Center here in Stavanger in Norway. And he's an experienced simulation educator with international experience from faculty development programs in Russia and in India. He is currently writing on his master thesis in pre-hospital critical care. I think, are you delivering that on Tuesday? Is that correct?
Can you hear me?
Yes, perfect. So you can understand that he's a bit nervous. He's been working with medical simulation since 2006 and has been educating paramedics, nurses, physicians, and medical teams for emergency medicine and patient safety all of this time. So with this, I pass the word over to you.
Thank you. Can you hear me?
I can.
Oh, that's good. I will share my screen. So can you see in the presentation?
Okay.
So do you see the slides?
Yes.
Thank you. Okay.
No, wait, stop. We cannot see your slides.
Okay. Try to start the presentations one more time.
It's always a bit complex when we're using a platform that we do not use that much on a day-to-day basis. So there's always something to learn. And Kjetil is sitting in his home office in Egersund, a nice little town, 2 hours or an hour and a half drive south from Stavanger. Very popular place for tourists who like to fish, especially people from Germany. Now these days, while he's trying to solve this issue, I can tell you that we don't expect that many fishing tourists this year, especially from Germany, but not from nowhere because of the travel restrictions. But Egersund is absolutely a very important city for that kind of thing. Are you able to start, Kjetil?
I'm working on it.
Something is happening here. There we go.
Okay, that's good. Okay, my name is Kjetil Torgersen. Thank you for the kind introduction, Bjørn. And thank you for inviting me to the webinar. Let me just adjust the screen here. So, I have a clinical background as well as working with simulation. I have been working for 25 years in the ambulance service as a paramedic, and when the hospital requested us to help in the I coordinated the training interventions done for the ambulance service. My colleagues Sverre Severson and Tor Harald Torsteinsbø performed most of the practical training, while Ørjan Undem, Kjetil, and Christian Søreide assisted with the intervention designs. So this was definitely a team effort. The first training intervention we designed for the ambulance service was skill training of ambulance-specific donning and doffing procedures. It also included the protective measures that needed to be applied to the patient. Videos of donning and doffing procedures were produced and were made available for the paramedics and the EMTs. In a situation with a massive pressure on the ambulance service, it was extremely important to avoid a situation with shortage of available ambulances. The EMTs and paramedics needed to learn how they could use, for example, the monitor equipment without contaminating the areas behind the barriers. They also needed to plan ahead and take out the medical equipment needed for the ambulance transport before loading the patient into the ambulance. If the protective barriers were broken, the decontamination procedure will take approximately 3 hours. Two of our facilitators visited all the ambulance stations in our district. All ambulance stations have a local facilitator, and they were trained to run the skill training and full-scale simulation for all the personnel on the station. The scenario we used was a dispatch to a suspected COVID-19 patient with chest pains. The simulation had two learning dimensions. First, the clinical experience with the learning objective to let participants experience the use of PPE equipment in a clinical context. The second dimension was system probing. Learning objectives for this was to identify gaps in practical use of PPE equipment in a clinical context. We identified several gaps and reported them back to management. The second intervention we designed was training for the EMT trainees. We conducted a 4-day simulation-based training for the first year EMT trainees, and the objectives was to prepare them for clinical work earlier in their apprenticeship than they normally would. This was due to a need for more clinical personnel available. The training was based on SAFER's existing training programs and included the use of e-learning, cognitive skill training, which I will elaborate in the next slides. And this training was followed by a webinar and also by practical, technical, and non-technical skill training and simulation. We have developed a model for cognitive skill training based on the principles originally designed by Hinse, and also been Gary Klein has done a lot of work with this model. We have adapted the model to also include full-scale simulation. Originally, this model for cognitive skill training was designed to enable trainees to shadow the thinking of experts. And Hinse developed this for training of firefighters in New York. The participants are presented to a clinical scenario and challenges related to the scenario. We use e-learning for the presentation of the case, and the participants start by individually write keywords on how they would solve problems and make decisions in the scenario. They can use literature or whatever resources would suit the purpose in this phase. Next step it would be to facilitate group discussions with the clinical experts in the room or joining by video conference, or expert thoughts could also be presented by short videos if that format would be more suitable. The last step would be a full-scale simulation of the same scenario. The experience we have gained from this model so far is very good, and we have gotten good feedback from participants when using it. Simulation also replaced clinical examinations, which could not be arranged due to the situation. That enabled examination to go according to plan. Postponing of these examinations could have had negative implications for future recruitment of EMTs. We also got a request from the university to do simulation-based training for the paramedics, first year's paramedic students, similar to the training that we did for the EMT trainees. The objective was to enable them to work as assistants in the ambulance service in case of shortage of staff. A 3-day simulation-based course was conducted for 24 participants. So the practical implications from the interventions that we did was, first of all, that both the EMTs and the paramedics will do more integrated simulation trainings in their educational plans. I think this quote from one of the participants is a really nice way of says it all. The participants found this extremely useful, and it's quite interesting to see how their own reflections on in comparison the simulation experience with clinical experience from real clinical situations. Yeah. Another thing that we are planning is to have paramedic students and EMTs to do regular simulation training together throughout all of their training programs. They have two different views on the education, while the EMTs have a very practical training. The paramedics have more a theoretical start of their careers, and to have them trained together, I think they can learn from each other's different standing or platforms. So that was what I had to share with you. So thank you for listening, and thank you for inviting me to the Sun meeting. Thank you.
Okay, let me see. There we are. Okay, thank you very much. So if you could just hang with us, Kjetil, because right now we're going to have the next presenter, which is Dr. or Professor Martin Krutz. Krutz. Sorry. We're going to have a Q&A session after this with all three of you. So basically, Martin, he comes from Freiburg in southwest Germany, by the border to France, in Alsace area, for those who are familiar with that. Freiburg is a very old and famous university city, and that's also where he studied medicine many years ago. So Professor Krutz is leading is the head of the stroke department here in Stavanger, and they have done a lot of interesting things regarding simulation. For instance, they have used simulations and some other means as well to reduce the door-to-needle time when a patient had a suspected stroke. But he has also been now working very closely with, among others, Sigurd Quindesland, that you heard earlier, with this project here. So I'd like to give the microphone to Professor Krutz. There you go.
Thanks a lot. Thanks for the introduction and the possibility to present our simulation, stroke simulation in COVID times for the community out there. Yes, thanks.
That one.
Yeah, perfect. Before talking about the COVID simulation, I will give you some background about stroke simulation at our hospital, Stavanger University Hospital. We were actually running quality improvement programs and projects in stroke treatment from 2009 onwards, and we're quite used to use these projects actively to improve our protocols and improve our quality in patient treatment. And from 2017 onwards, we used actively simulation training in stroke at Stavanger University Hospital as an educational tool on a regular basis. And we started with intravenous thrombolysis simulation tool in 2017, and then we expanded after we recognized the effect of simulation to the pre-hospital phase, including the ambulance transport and paramedics picking up the patients, and the mechanical thrombectomy using the Siemens vascular to train the assembly in the EVT and the task training of EVT at the same time. We have, as Sikunanna and Kjetil introduced already, a big advantage in Stavanger, and this advantage is that we have a culture for simulation training in Stavanger Hospital. There is a lot of simulation training ongoing for a long time, and a few of them are, Sikunanna has told you about them already: newborn simulation, trauma, cardiac arrest, critically ill patient. So it was quite easy for us as stroke neurologists to implement stroke simulation training on this cultural background that was settled in the hospital already. And then we have the big advantage that we have SAFER in the city, and SAFER is the local simulation center, as Sikunanna told you already. And it was established by Stavanger University Hospital in cooperation with Stavanger University and Lærdal Medical back in 2006. And they have a lot of huge experience in simulation guidance and in simulation training. And thus, by that guidance, it was quite easy for us to start with a simulation training for stroke. And even more important, that we recognize that simulation training is kind of a teamwork. No one is accomplishing that alone. And just to picture some of the key persons being involved in the simulation training throughout, You see Sigrun, the third person, the rest I will not tell you a lot of these people due to time constraints, but there are a lot more people involved in simulation training. The results of our simulation training in Stoke were quite astonishing for us. We had an immediate reduction, and I mean immediate, right from the start of implementation of the simulation training, from a reduction from the door to needle time, also when the patient come into the hospital, until the treatment was administered, from 29 minutes to 13 minutes. And we kept that 13 minutes door to needle time throughout the first 6 months and ever after, actually. We have a door to needle time that is in median, depends a little bit on the change of the assistant doctors, between 13 and 15 minutes for the last 3 years, actually. And what was even more astonishing, that after 1 year of simulation training, we could realize and analyze that we had a reduction in stroke mortality and a reduction in stroke morbidity. And these results are now published last year in Quality and Safety BMJ. And there as well, if you have more questions, the protocols are standing there, and more of the supplemental material, you can get more information about the stroke experience in Stavanger by reading that paper or contacting, of course, me or the first author of this paper. After that experience that we made in stroke simulation training, we actually had the question, what can we do with simulation training in the COVID setting? And was quite clear the question, how does COVID-19 affect the stroke team and the delivery of treatment, stroke treatment? And of course, we recognized that the infectious disease control is of utmost importance in that issue, and health workers at higher risk of obtaining and transmitting the virus. Their families are at risk. They have an individual risk, but they have as well a risk of transmitting the infection to colleagues, and then they put the colleagues and the families of the colleagues at risk, and the disease spreading in the hospital as well. And this leads to a staff shortage in many parts of the hospitals. You saw that in Spain, you saw that in Italy. And this new situation is leading to a big uncertainty among the physicians, and especially the stroke physicians and the neurologists. They were actually scared in our hospital, and they used the simulation training actively for fighting against that scare, actually. And the numerous new regulations all the time from the health ministry and from the hospital administration released protocols in a rapid succession that made them not even more sure, but made simulation more important in that aspect, to train the new protocols and to get familiar with the new protocols, actually. So the question was, well, how can simulation training help to improve the stroke treatment? And of course, we use simulation training in stroke treatment to identify the latent safety threats that are in the protocols. And we use the simulation training to adapt the protocols iteratively. We practice the new protocols, including the PPE protection. People are not used to that. And by practicing and getting familiar to these protocols, we reduced the mental strain of the healthcare workers. We had less scared colleagues, and we felt we were more familiar to meet the COVID-19 patients presenting with a stroke at our hospital. And the consequences, of course, are that we had or wanted to achieve less infectious spreading in the hospital, both the colleagues or the patients, that more healthcare workers were available and not quarantined. And this leads, of course, as well for a better patient outcome, because the protocols, the changed protocols with the PPE, if you know what to do, you have quicker patient treatment and probably as well better patient outcomes by that. Simulation experience, Sigrun had told you already that we couldn't afford to use real simulation PPE due to a shortage of worldwide of the PPE that had to be used in COVID situations. So we tailored our own simulation PPE that we could use in simulation training. And with these PPE things, we set up the intravenous thrombolysis using a COVID protocol, using a human marker, actually. We used to have human markers from the patient organization LOL here in Rogaland, but we didn't use these markers as they were external patients, and we were scared to get infectious spreading into the hospital. So for the COVID protocol, we used colleagues actually as human markers. And for the endovascular training in COVID, we used the cement vascular from Lærdal. And we exchanged the human marker by the simulation mannequin before the angiosuit, and thus we could use the angiography assembly and training of the thrombectomy in the COVID situation as well. The debrief was done in an extra room, actually, where we had where you could assemble all of the people being in the simulation and where they could have the distance of 2 meters, and there we could discuss the simulation experience and implement the learning points into the protocol. And the debrief, of course, had a focus on time and patient treatment, but main focus of the debrief was on the infectious spreading and reduction of the infectious spreading, and to improve the protocols being in the hospitals. I have you 3 examples here. There's one from the intravenous thrombolysis training. Normally we have as well the paramedics with us here. Now it's just me. I was the paramedic in that case, having the GoPro handheld or on the head-mounted GoPro. And you see here the assistant doctor. He's investigating, Dr. Risai from my office, a good colleague, senior consultant in neurology, doing the patient marker here. And you see that they wear the PPE that we tailored for the simulation experience. Next one is the angiosuit, where we have the sim and vascular, and in front of that is Kjetil Sandve. He's just the facilitator for the technical stuff with the simulator. He's fixing here some things. And the rest of the team is focusing on the communication and the treatment in the COVID situation. They have the training PPE on, and the interventional radiologist is performing here the mechanical thrombectomy. And that's quite a silent simulation here, but we had as well challenges in the situations where the patient, the anesthesia method had got to be changed from a conscious sedation to intubation with a change of PPE equipment and things like that. So you can get familiar with these situations, and it helped us a lot in our experience. So what did we reveal with the stroke simulation training at our hospital? The first thing is actually that we were quite sure and that we had collaboration with infectious disease control staff. We didn't interact very much with them before, but there we had a really close interaction all the time and had them with us to improve the protocols. And this was really helpful for everyone and all of us. I picked out 3 challenges here and how we solved them. And the first challenge I present you here is that we had, of course, insufficient communication between the paramedics and the in-house medical team regarding the COVID situation and respiratory situation. It's not part of the standard stroke protocol. It's not trained. So we put that into the protocol and trained the paramedics and the team regarding these questions, and the team then called the team inside, and then they gave relevant information already before entering the hospital. And in the initial report, those that the team in the hospital, they could prepare about whether it was a COVID patient or not a COVID patient, what is really important in that setting. The second challenge we addressed was, of course, that we had insufficient practice and experience with the use of PPE, personal protection equipment. Especially neurologists are not really used to use that. And by having sessions where we just practiced the donning and doffing of the PPE, that reduced the mental strain in the acute situation, because everyone knew what to do, and we didn't use 2 sets that we can actually spare the PPE material in the real cases as well, because we used it right the first time. And I think that's important as well when the stuff shortage, or the shortage of the P material worldwide. So it was important to us to get that point with us in the training. The third challenge I want to present you is that we actually in the protocol, we kind of recognized that with inefficient workflows and communication between the team in the COVID situation, as our neurologist normally comes from the CT operation room, joins the radiologist to the CT control room, to discuss the neuroimaging and the consequences of the neuroimaging in the acute situation. This couldn't be done in the COVID situation, because the neurologist was dressed in the PPE and he was in contact with the COVID patients. Thus, we had to make changes, and we invented a lead protection wall, a portable lead protection wall that we could put into the scanner room in COVID situations, and then the neurologist could stand in the PPE below or behind that protection wall and have the communication as he used to be with the radiologist. That was a big advantage in that situation. And here you see the LED protection wall as we installed it in the CT scanner room. That was quite important for us to keep the protocol as it was actually, but with the COVID precautions we had to take. The results of the simulation training, of course, we're still simulating and we're collecting experience with that, but we had done a pre-simulation assessment where it showed up that only 15% of the simulation participants were completely comfortable with being in that role in the COVID-19 stroke team workflow. They were scared of being infected self or in transmitting the disease. And what's really astonishing that after one simulation cycle, this number of the people being confident increased to 80%. So simulation training really helped us to make people confident in the situation. And as well, over 60% of the participants stated that they identified at least one latent safety threat that helped us to improve the protocols. And the protocols were thus adaptive, improved iteratively, and we're still doing that. We used actually the simulation training actively to get the protocols in place, to get them better. And they, after every simulation training, literally we changed some tiny parts or bigger parts in the protocol and felt that we got more and more control. And thus the simulation training really helped us to develop protocols and getting that right. I have not time now because of the 50 minutes limitation to show more results and details about that stroke experience, but we actually published now this month a paper in Stroke, a special report about the details of the stroke experience, whereas as well supplemental material. So you can read more details there if you want, or contact me, of course, by mail if you want to. Thanks for your attention.
Thank you very much. So just to check, am I on now? Yes, I am. Good. All right. So we have come to the question and answers. I wonder if you could, if you could take the microphone there, and we have this ruler here just to make sure we have the right distance between you two too. Yeah, that's fine. That's good. Then we started. Do we have our friend from Megastream there? Yes,
I'm here.
we do. I'm just looking for my headphones. There's always something. Okay, there we go. Are you there?
I'm here.
Oh, that's great. So let's start with you, Sigurd. You have touched on organizational aspects and how important they are in influencing the ability of hospitals to engage their simulation staff. What advice would you give to simulation educators and leaders on how to engage with efficient training to achieve results?
Thanks, Björn, for the question. I think it's incredibly important for everyone working in simulation to collaborate with the clinical leads, the administrative leads, and together define the challenges and together decide what can be helped by skills training or simulation. And it's incredibly important when you're working in simulation. Yes, we're all very happy that we managed to make it happen and we succeed that people participate, but you have to collect the results. Like Martin told us about at least how people's confidence increased, and then they identified latent system errors and feed that back into the system. So you have to be an educator, but you have to be interested in improving the quality of the system, work together with people who know safety methods, quality improvement methods, be a team, be a really good team that works together to use simulation smart for your organization and make sure they know the results.
That's great. To you, yeah, I have a question here. You know, when you perform these simulations, I see here from your videos, you're doing a lot in situ at the hospital, yes, which is actually also where patients are treated. Will that lead to some you know, extra a burden for the hospital? I mean, you have to clean it down to be able to receive the next patient. I mean, you have the same situation as if this was a real patient, right?
Right. Yeah. I think it's the opposite, actually, that the training enables us to treat the patients accordingly and to do it properly. And I think what we told earlier on, that there is a culture of simulation training. It's just the COVID situation just made it evident for us that the simulation training is not a burden to the hospital, but a possibility to quickly change protocols and to get things in place in a really quick pace. So this was very helpful, this simulation experience.
Right, but you do need an open room, you know.
Yeah, but we use the teams being on call, so it's not additional teams, it's not the same. So the in situ, it's not really cost effective for the hospital. We made as well calculations to that to be published now. So it's not really a big point of use teams in place there, I guess.
Kjetil, a question to you. When thinking about the training of pre-hospital personnel, I know that the issue of you know, multi-resistant as a bacteria, a patient with a possible multi-resistant bacteria, also is quite demanding for pre-hospital personnel. And is this something that you think that the hospital have been able to build on as a positive experience when they now have to, you know, consider the issues with the COVID-19?
I think that both the organization and the individuals have learned a lot from the situation. I think that the protocols had to be rewritten many times. They were almost updated daily. And I think that the knowledge that have been gained along the way, and the experience both from the simulation and from the clinical practice, have given many learning points for both the individual and the organization.
I see. All right, great. And Martin, another question for you. During this COVID-19 period, your simulation team engaged in neurology residents. Thank you. As stroke patients. Can you tell us about their reaction to their role?
Yes, of course. We usually have human markers from the patient organization. I think this is really important to us, that we have former patients presenting the symptoms, because we can as well in the debrief check about the patient experience, how this is felt by the patients, whether they were scared, whether they felt that the team was taking care of them in that situation, not just medically, but as well psychologically. And I think for us and the patient, it was the residents being patients, or me being a patient as well. It's really an overwhelming experience being in the ambulance, and then on the ambulance stretcher and passing just the hospital floors and just seeing the lights going. It's so you understand it's a scaring situation, and that the stroke physician, they meet you in the enterprise PPE and then have the face mask on. So this is quite scary, and this is of course it's very, very healthy and good for the residents to feel how it feels for the patient side, and the patient to get the patient perspective in place for themselves.
Because as an added benefit, they will actually start to feel how it is to be a patient,
right?
And hence maybe be able to develop another level of respect for the next real patient they meet.
Yes, we have a big focus on that in the normal simulation already, because we have the former stroke patients in the simulation. But I think it's a next level of the experience if you are the patient and experience that by yourself. So this is, of course, an important experience.
Hilda, another question for you. They came from one of our viewers. So you made a lot of your own protection material. So did you make a lot? I mean, you know, it takes some time also you need to wash them and clean them, or was it like personal?
Thanks for the question. This was one use only. We have to be incredibly accountable when we run simulation that we don't introduce risk and safety threats into the environment. So we made a decision that we didn't have the logistics to wash this simulated PPE. So we were just going to make it one use only, and the mask will be thrown away. And the gowns, we had a very nice agreement with the hospital cleaning service that these are cloth gowns that can be washed. So they were one use only, put them in special bags, get them back to the laundry and return. Excellent help, again, with the different silos or staffs or functions at the hospital that collaborate to make a good enterprise. So,
perfect. Yeah. Last question. I can ask the same question to all of you, starting with you, Kjetil. Was there something that really surprised you with this project?
surprised. One of the things that was kind of unexpected, I think, both for me and for the people in the ambulance service, was to see the kind of how fast the management implemented their input. They took action when gaps were identified and things were really fixed in a hurry. Usually these things takes a lot of time, but now they gave input and the day after things were fixed. I think that surprised both me and the people in the ambulance service.
I can understand that. And what about you, Sigrun? Is there something that surprised with this process you have been through this spring?
I don't know if it was a surprise, but I guess it confirmed what I've hoped for years. I mean, you have to be very highly motivated to work for years in education and simulation in very busy hospitals. So I think it just confirmed the use of simulation as a learning method and as a system improvement. Intense experience with clinicians that didn't want to leave debriefings. They were so concerned with improving care, and they were so concerned with getting it right. It was a pleasure after years of lots of hard work. So keep up the motivation and keep up the hard work out there.
And you? Anything that surprised you? You've been doing simulation, both of you, for all three of you, for many years. But this is a very, very special situation we have all lived through this spring. Is there something that surprised you?
Actually, thanks for the question. Not really. I'm not really surprised. If you have a look at the people and the collaborators we have at the hospital and how highly motivated they are and what they can achieve. So it was a pleasure to see that we could use simulation experience as a tool to implement and improve protocols. And I think this was the new experience that we used actively, not to teach the assistants and the healthcare workers, but we drew the essence out of the simulation to improve protocols all the way. And this was a really astonishing experience.
So this was more like a confirmation that you are on the right track system-wise than surprise.
Both, of course. It's very it's incredibly nice to see that everything works quickly and sure. can be done quickly. But we have the good people all around and with the good collaboration. So it was nice to see that it worked in that crisis situation.
Well, thank you very much. By this ends the second hour. Sorry. We are now going to have a little break, counting down to the next full hour. Where we start again, and my colleague from the US will take over, and we will visit UK and later US. So have a little break and be ready in 2-3 minutes. Thank you.